To get started, we're going to start off with Dr. Freak-Poli, who came all the way from Australia to give her talk today on gender-specific population attributable fractions for cardiovascular disease and all-cause mortality associated with living arrangement in community-dwelling older people.
Thank you. One bit further. I acknowledge the traditional owners of the lands on which I predominantly work and live, the Wurundjeri Woi-wurrung people of the Kulin Nation, and the traditional owners of the many lands on which you may work and reside. I pay my respects to their elders, past and present, and the elders of other communities who may be here today or online. Before I show you any data, I just want to discuss where it's come from. The participants are from the Esprit trial, which was a randomised controlled trial of low-dose aspirin versus a placebo. They had to be healthy on recruitment, meaning that they had to reach age 65 or 70 with no prior cardiovascular disease, cognitive decline or cancer. They could have had skin cancer, but that had to be at least 5 years ago. Majority of the sample was from Australia, but we did have some funding from NIH and prioritised your priority populations, as in the culturally and linguistically diverse communities that you have here that we don't have in Australia. And we have a huge range of sub-studies from this study. So one of them is a biobank, if that is something you're interested in, and one is a social survey, which is where I get most of my data from. The majority of the Australian sample did participate in the social sample, but collectively, just to point out that people reaching the age of 75 years or more in Australia tend to be white and economically advantaged. I'm more happy to talk about this during the question time, specifically about how the White Australia policy impacts this cohort. So to start, I wanted to start with a bit of a backstory about how I came to living arrangement. I was funded by the Heart Foundation in Australia to look at social isolation as a risk factor for cardiovascular disease. And what I found was that if someone was socially isolated, they had a 66% greater increased risk of having a cardiovascular disease in the next 5 years. If they had low social support, the risk was double. If they were lonely, they had 255% increased risk of dying from cardiovascular disease. Now, I thought that was, a good contribution to the literature, but it started making me think about what the population health messages would be around this. I continued this work with my PhD student, Achamyeleh Teshale, and we put all the different social variables in looking at whether they could be protective of cardiovascular disease. Now, all of the variables shown on this slide were statistically significant in univariable models. And then when we put all the variables in together in the multivariate models, the one in bold were the ones that had the strongest relationships. Married or being partnered had a collinear relationship with living with someone. So we had to do 2 separate models for those. And what we found was that living with someone was statistically significantly protective of cardiovascular disease for men and women. Very excitingly, this made our national news in Australia. That's me live on television. I also was interviewed on Drive ABC, which is when everyone's in their cars driving home, which is really cool. And what I really loved about this media coverage, it was the first time I'd had strength-based findings in the media. Before that, they were always interested in the deficit model of loneliness being bad for you. So I felt like this was a huge step for me. We continued looking at CVD prediction with AI models and social determinants to try to summarise 3 papers really fast. We used deep learning AIs because they were outperforming traditional machine learning techniques. We added in social determinants with the traditional risk factors for cardiovascular disease, and we found that a number were surpassing well-established biographical or biomedical risk factors. Among those was social networks, living arrangements, and indicators of socioeconomic advantage. At the same time as this work, I had another PhD student, Hetland Hutt, who was also looking at similar analyses, but with dementia as the outcome. And we were finding there living arrangements was also a really strong predictor of dementia in both men and women. So we decided to look at this a little bit more. This is a graph of one-person households or people living alone as a percentage of all US households. As we can see here, in 1940, the percentage was 7.7%, and then it increases steadily until 2020, where the percentage was 37.6%. Over this 60-year period, it's increased 5 times the number of people living alone. And this pattern is repeated in Australia and other economically advanced countries. So what is the implications of this on our health? Well, we know from the literature that living alone is associated with a risk of cardiovascular disease incidence and mortality, as well as all-cause mortality. And there was varying findings when people base this on stratified gender. So we don't know if men or women are having a worse or better time living alone. So hence we did a population attributable fraction. I heard that there's some PAF experts here in the audience, so that's the equation we use because we know there's different equations. But for people who don't know what a PAF is it that it indicates the percentage of diseases or deaths that could potentially be prevented by eliminating the risk factor. So for example, what if no one in the population smoked cigarettes? Or in this case, what if no one lived alone? I wanted to look at exposure variables 2 different ways. One was living completely alone versus not. And the second is living with a partner or spouse versus not. There's another category where people can live with a relative or friend that's not their spouse. And so by looking at both of these, I can make sort of inferences about what the benefit is of living with a non-spouse but relative or friend. We have a huge range of potential confounders that we included, including all the domains of social determinants of health and the traditional risk factors for cardiovascular disease. People were followed up to 12 years, and that ended up to be about a median time of 8 years. What's key here is that men had a greater rate of cardiovascular disease and all-cause mortality than women over that time period. And women were more likely to live alone or not live with a partner. And I think we see this in other countries as well. So here are the results. In the PAF models, the only significant association we found was that was that not living with a partner or spouse was associated with all-cause mortality. For women, all the combinations were associated, and I'm going to go into a bit more detail in the next slide. So I'm going to focus here for a little while just to recap that women are more likely to live without a partner or live alone. Women are at greater risk of cardiovascular disease and all-cause mortality when living without a partner or living alone. And the PAFs show that men not living with a spouse attributes to 6% of all-cause mortalities, whereas women not living with a spouse attributes to 13.5% of cardiovascular disease incidence and nearly 10% of all-cause mortalities, whereas women living alone attributes to 14% of cardiovascular disease and 12% of all-cause mortalities. Earlier I said that I was interested in that group between living with your spouse but not living completely alone, which is living with family and friends. From this I can infer that living with family, if you live with family and friends, it's an additional 5% attribute all-cause mortality for women. So that's looking at the difference between the 10% and the 12%, compared to living with a spouse. So that's the only difference we found. So there was no difference between, you can see the difference between not living with a spouse and living alone for women is quite close. So there was no difference for the spouse. Sorry, I'm confusing myself here. The spouse, there's no difference between living with a spouse or a family, friend or a relative for cardiovascular disease, but there was a difference for all-cause mortality. So the last thing to say is solutions. There's something called social prescribing, where doctors prescribe social activities instead of medications, and preferably this includes a link worker or community connector that can have the time to look at personalised solutions. There's also proactive health monitoring, particularly for women living alone. So these are daily phone calls and kettle alarms, where if they're not available, then people will come to their house to check on them. And I just want to say thank you to my amazing Gold Star PhD students, Achamyeleh Teshale and Hetlin He. Thank you.
Hi, great presentation. I really enjoyed learning about that, and my research is closely related, so it was great to see that this is being searched upon in a different country. I had a question about the confounders that you had posted. Did you find that any of those confounders were maybe very closely related to the exposure, like very, very closely, that they could have like affected like the model at all? Or like, how do you tease that apart?
So we do look at the correlations, and the most correlated was the living alone to spouse marital relationship, which is why we've always done two models. So not prioritising one or the other, but just making sure that the evidence is similar, and not including collinearity. But none of the others had a strong relationship with each other or with the outcomes determinants.
Great work, Xiao Zhongwen from University of Buffalo. I really wondering like the mechanisms of for the association between living alone and the CVD risk. The reason why I asked that is because what kind of thing we can do, right? Towards the end, you mentioned like community prescribing and also some alternative ways like daily checking. If those are like mechanisms, that would be good. But if not, those may not be able to replace living with other people. Can you talk a little bit about that?
So the question is around the solutions for
Yes.
the situation. Yes, so there's a lot of literature that talks about not only like the better quality of life, less loneliness, that would also benefit cardiovascular disease risk and mortality. So I think it's the availability of someone being in your life consistently, and sort of that checking in and making sure that everything's fine. So neighbours is a big one that we've come across. Knowing at least 4 to preferably 7 of your neighbours can help, particularly for loneliness. But I think that also helps if because people check on each other. I know, for instance, that there's groups of women that will check on each other every day. They just go past this house. So there are things that people can do that I think would be effective, but it's not run necessarily as a program.
Oh, okay. Sounds like the mechanism is more like communications or caring. Is that?
I believe it's probably there's two. This is my personal opinion from reading the literature. There's two things. So people that lived alone may not feel like they have something. They have a health issue, they're more likely to delay to get it seen or, discuss it with a health professional. If you live with someone, you're more likely maybe just mention it, and then that makes you go to see the health professional. So this I feel like just living with someone makes you reflect on your own health differently and seeking advice.
Okay.
But the other thing is if something bad happens to you, someone that lives with you is more likely to find you sooner to get you to hospital.
Or something happened, then someone
If something
will take care of
happens-
you.
They're physically
Okay.
there, right?
That makes
so
sense.
if you're living alone, you could be home alone for a long time. And there
Yes.
has been an incident, particularly in Sydney, where someone living alone wasn't found for 7 years.
Oh,
No
so
one
you
checked
can
on it
meet-
for 7 years.
Oh, wow.
So there are, when we're talking about people living alone, there's real differences with how that works on a daily basis for each individual. Some people are very isolated and living alone, and others are very proactively out there in the community and living alone. So that it's not a broad sweep.
Perfect. Thank you so
Thank
much.
you. Very much.
Sorry, I actually have one question.
Thank you.
Have you looked at incidence of cardiovascular disease, not just mortality, to see if living alone is also associated with higher incidence of cardiovascular disease?
Sorry, maybe I would have to go back, but I believe it was incidence. I was talking
you were
about.
just talking about mortality.
Sorry,
so then
incidence.
cardiovascular incidence, not mortality.
Cardiovascular disease incidence, and then
All-cause
all-cause mortality.
Okay,
Sorry, my apologies if that wasn't clear.
Okay.
And in that example, I was trying to say that if something happens, then they're more likely to get help to prevent them from potentially dying or
But they would still
otherwise
be
have had the
getting
incident.
cardiovascular disease.
Yes.
So
Yeah, sorry.
how does that I guess I'm trying to understand.
I probably said it a little bit convolutedly. I'll say it very simply. I try to say it more simply. So if you're living with someone, your perception of your health might be different because you may mention it and then that makes you be more proactive about a pain or an ailment, and that then prevents you from future health incidents such as a cardiovascular disease. But then also if you're living with someone, they're more likely to find you if you're unable to look after yourself and care for you, and that might reduce the impact of or the severity of a disease.
Okay.
Does that help? Thank you. Thank you.